Good morning everybody, and first and foremost, sorry for not being with you during this weekend due to unforeseen circumstances. This course has rapidly become one of the most important courses in nephrology, certainly in the UK, if not in Europe, and it's also taken an international dimension as the Preston Renal Biopsy course, and I'm delighted to be participating somehow in its third edition. The friendship, this slide shows you, it's quite an old slide actually, and as you can probably tell, but it shows you the long-standing friendship I have with Eamon and the respect and admiration I have for what he has achieved in recent years, and including the Preston course that he has set up some 3 years ago and has progressively and steadily developed to become an international course and one of the main ones in renal histopathology, as I said, in the UK and Europe. So what I'd like to do today is to stress the fact that many of you, when you practice nephrology, don't bother to look at renal biopsies yourselves and tend to rely on the pathology report and take appropriate action or inappropriate action based on its conclusion. So I think it's very important for a nephrologist to be able to look at a biopsy himself, to interpret a renal biopsy himself, and also to be able to understand what the pathologist means by his or her report. And I would also like to, so I'll start the first half of my talk taking you through the basics of interpreting a renal biopsy, but during the second half of my talk I'd like to put more emphasis on clinical pathological correlations and how, by, for instance, interpreting a clinical presentation, one can deduce the underlying pathology. So looking at the renal biopsy is really a detective work, as we will look at all aspects of renal biopsy. First and foremost, there are requirements. The renal biopsy specimen has to be adequate, has to have sufficient glomeruli to be able to reach some conclusion, and has to be representative of the overall renal histopathology. It has to include glomeruli, it has to include tubule, it has to include a significant interstitial area, and also has to include representative number of vessels. So we'll be looking at glomeruli, the tubular interstitium, and the vasculature of renal biopsies. It's also important, and that is an issue in emerging countries, whereby histology is confined to light microscopy, and it's important to know that in order to have a more holistic and comprehensive view of kidney histology, that one needs to evaluate a kidney biopsy by light microscopy, by immunofluorescence, and by electron microscopy. First and foremost, light microscopy, and the sections have to be well processed. So the technical aspects of cutting and staining the section is important in itself. Sections shouldn't be too thin and shouldn't be too thick. Thick section will give you false appearance of thickened elements of the histology and the morphology, like thickened basement membranes, thickened mesangium, and also will give you hypercellularity due to the fact that the section includes more nuclei and more cells than a thinner one. And on average, 4-micron sections seem to be optimal for light microscopy examination. Following processing of a light microscope section, staining is also important. So hematoxylin and eosin H and E gives you a general appearance of the biopsy. Mason trichrome puts more emphasis on the extracellular matrix and collagenous aspects of the biopsy, along with periodic acid shift. Silver stain also puts a lot of emphasis on the basement membrane, and whether it's glomerular basement membrane or tubular basement membrane, therefore putting emphasis on the collagenous part of the kidney biopsy. Congo or Sirius red is a more specialized stain that is important to undertake as it highlights the presence or absence of renal amyloidosis. Following light microscopy, and you can see that light microscopy has many elements and many stainings to it. So it's not just one section containing 2 or 3 glomeruli. You should have at least 10 glomeruli, well representing the whole histology in terms of tubules and vasculature, and a range of stainings to obtain the optimal information that you require from the light microscope. Then you have immunofluorescence, mainly highlighting the presence of immunoglobulin and their distribution within the glomeruli. So here on the right you've got mesangial IgA, and you can see that the staining is localized within the mesangial area. To the left you've got a more diffused granular staining along the glomerular basement membrane of immunoglobulins, as for instance membranous or membranoproliferative glomerulonephritis. But obviously you can't localize the staining. All you can say is that you've got granular staining, not linear, and that it is in a glomerular basement membrane distribution, unlike the one on the right, where you can say you've got immunoglobulin staining in a mesangial distribution. And depending on the type of immunoglobulin you stain, IgA, IgG or IgM, you can specify what is the immunoglobulin or complement deposited in the glomeruli. Here you've got 2 other examples. The linear staining, which is not as granular and disrupted as the previous one of immune complexes, and that's more characteristic of autoantibody and antiglomerular basement membrane antibodies staining in a linear fashion along the glomerular basement membrane. Contrast this with this glomerular tuft that has no staining in it, post-immune or non-immune deposit within the tuft, as in ANCA-associated or necrotizing glomerulonephritis, and in this instance most of the staining is localized within the crescent that you see here highlighted by fibrin deposition and immunofluorescence for fibrin. So ANCA-associated vasculitis, necrotizing glomerulonephritis when there aren't any cells left, therefore no immune deposits. Here on the other hand you've got linear staining of anti-GBM or Guttbarsch's syndrome. Then we look at electron microscopy, and again we need to be familiar with the different aspects of electron micrograph, especially of the glomeruli. And here you have a normal electron micrograph with a fenestrated glomerular endothelial cell, the basement membrane, and on the urinary side the podocyte, the visceral epithelial cells, with its very well delineated healthy foot processes with in between interdigitating slit diaphragms through which the albumin and protein filters. The thickness and cross-section of the glomerular basement membrane tends to be around 150 to 250, 300 nanometer in cross-section, and obviously thin membrane disease will be half that thickness, less than 150 nanometer, and thickened basement membrane can exceed 500 nanometer in thickness. Thickening usually either due to diabetes, for instance, or immune deposits, such as in this case, where the immune deposits are subepithelial, as in membranous nephropathy, and you can see that the basement membrane underneath the endothelium is clear, but underneath the epithelium is quite thickened. Another example of thickened basement membrane, mesangiocapillary glomerulonephritis, where again the membrane is quite thickened, but this time there's the epithelial cell, there's the urinary Bowman space, no deposits along the epithelial side, but the deposits are more subendothelial, endothelial cells, subendothelial, and intramembranous. And mesangiocapillary also has the characteristics of these extension of mesangial cells interposing themselves into the basement membrane, trying to clear the immune deposits. And we'll come back to this mesangial interposition, but very often it gives the appearance of a split basement membrane. You've got on one side basement membrane, then no basement membrane because you've got a mesangial cell extending, and then another basement membrane, hence the appearance of split. But again, the basement membrane is thickened, 500 nanometer or thereabout, due to immune deposition and due to cellular infiltration. So let's start our detective work with the glomeruli first. And when you look at the glomeruli, you look at glomerular cellularities, you look at patent intraglomerular capillary, you look at the Bowman space to see if it's clear for urine filtration, you look at different elements of cellularity, endothelial cell, mesangial cell, podocytes, but you also look at extrinsic cellularity, infiltrating neutrophil, infiltrating monocyte, and macrophage forming crescentic cellular aggregation and glomerular crescents. You also look at the matrix, whether it's expanded and whether there is mesangial expansion, and ultimately you look at scarring, whether there is segmental part of the glomeruli or global, the whole glomerulus being fibrosed or sclerosed. So always you have to keep in mind with a 4 micron cross section what the normal glomerulus looks like, and from there you'll have a clearer understanding of pathology. So cell number shouldn't exceed about 50 to 60 cells per cross section. The glomerular capillary lumen should be nice and patent, and the urine Bowman space should be nice and clear, allowing for filtration. Cells in between glomerular capillaries, these are the mesangial cells. Cells lining the glomerular capillary lumen, as in here, will be an endothelial cells, and cell lining the outside or the external aspect, the urinary side of the glomerula, will be the podocyte, the visceral epithelial cell. Cells lining the Bowman's capsule will be the parietal epithelial cell. So remember all these aspects. Mesangial cells, mesangial matrix around it, holding the glomerular basement membrane intact. The lumen of the glomerular capillaries, nice and patent, and the urinary space, nice and patent. Because when we'll come and talk about clinical pathological correlation, we'll understand hematuria, we'll understand proteinuria, and we'll also understand impaired kidney function through these 4 or 5 variables. So we start with glomerular intrinsic proliferation. That is the proliferation of glomerular intrinsic cells, predominantly mesangial cell. And here you can see, instead of having 2 or 3 mesangial cell per capillary loop, suddenly we have up to 5, 6, 10 mesangial cell forming small cellular aggregates within the mesangium, along with, usually associated with extension of the hyaline material around the mesangium. The basement membrane is thin and normal. The capillaries are nice and patent, therefore filtration is possible, although the Bowman space, because of the proliferation and extension of the glomerular tuft, is somewhat reduced and squashed, and this may impede on kidney function. But the basement membrane is normal, the podocytes are normal, therefore unlikely to have proteinuria, and mesangial disruption and proliferation will give us hematuria. Now the opposite, GBM thickening, normal number of cells, 50 to 60 cell per 4 micron light microscope section. And now there isn't cellular proliferation. The mesangial cell, 2 or 3 per loop, no more. But there is thickening of the glomerular capillary wall, and you can see it at the periphery. And you also can see that the glomerular capillary lumen is somewhat reduced in size due to thickening of the glomerular capillary walls. So the filtration area within the glomeruli may be somewhat reduced, although the urinary space seems to be fairly normal. No proliferation, but thickening of the basement membrane, and we'll see the thickening of the basement membrane and the associated podocyte abnormalities will give us proteinuria. So it's membranous rather than proliferative. And again, with membranous, you have subepithelial immune deposits. And you can have a combination of both. You can have glomerular cellular proliferation, and you can see a marked cellular proliferation here, along with thickening and splitting even of the glomerular basement membrane. And that is typical of mesangio, capillary glomerulonephritis, or membrano, thickening of the membrane, proliferation of mesangial cell, glomerulonephritis. And this is when you see the subendothelial deposits or intermembranous deposit, but there is also proliferation. You can see the mesangial cell proliferating and infiltrating and getting into the basement membrane. And to the right, you've got a nice diagrammatic representation of the process. The abnormal podocytes and the thickened basement membrane, the abnormal podocyte in green, sitting on top of a thickened basement membrane, which is split due to the red interposition of mesangial cells. So thickened basement membrane and red interposition of mesangial cell, leading to proteinuria, but also the proliferating mesangial cells causing hematuria. And we'll come back to these correlation later on. So you can have proliferation of endogenous cell, mesangial cells. You can have thickening of the basement membrane, as in membranous or membranoproliferative, or even in diabetic nephropathy. But you can also get extrinsic proliferation into the glomeruli of infiltrating cell, and it really should be called glomerular inflammatory proliferation. Again, normal glomerulus, normal capillary pattern, normal urinary space, and now look at the inflamed post-infectious glomerulonephritis with diffuse or global within the whole glomeruli, diffuse within all the glomeruli, infiltrating of the glomerular duct by leukocyte and neutrophils, causing edema and also causing the obstruction of the glomerular capillary lumen. You can see hardly any patent glomerular lumen allowing filtration due to the edema and due to the severe infiltration by inflammatory cell within the glomerular capillary duct. And you can see that the glomerular infiltration, swelling and proliferation also impedes on and hardly leaves any Bowman space for urine to filter. An inflammatory cell will damage the glomeruli, will damage the glomerular basement membrane and disrupt it, leading to proteinuria and hematuria, but also the occlusion of the intraglomerular tuft capillaries, and the Bowman space will hardly leave much room for filtration, therefore renal function will be impaired. Another form of extrinsic cellular proliferation, instead of neutrophil, this time is macrophages and monocytes infiltrating the Bowman space and eating and squashing the remaining glomerular tuft. So the glomerular tuft is steadily destroyed and shrunken and replaced and pushed by these aggregates of cells obstructing and occluding the urine filtering space or the Bowman space. Therefore, you have acute kidney injury, no room for filtration, as well as a destructive glomerulonephritis. Destruction of the glomeruli and its basement membrane will lead to proteinuria and heavy hematuria, because the membrane is no longer impermeable to protein and red cells. But now you also have severe renal impairment due to the fact that there's no urinary space for the filtrate to get to. So instead of internal occlusion of the capillary, you have extracapillary proliferation and occlusion of the filtering Bowman space and acute kidney injury. Another example of crescentic glomerulonephritis, and now you see that the damage also affects the Bowman's capsule, allowing these monocytes and lymphocytes and macrophage to infiltrate the urinary space, proliferate within the urine space, and occluded and impeding and affecting filtration, therefore causing a severely impaired renal function, as in rapidly progressive glomerulonephritis. This picture of necrotizing as well as crescentic glomerulonephritis, and the cells for crescent formation either come from damaged glomerular basement membrane, in other words, intrinsic capillaries that leak these cells, or as you can see here, from the interstitial through broken Bowman's capsule into the urinary space, and in either case you'll get severe renal function impairment. This picture is more typical of an ANCA-associated necrotizing glomerulonephritis. And all these changes, whether they are endogenous proliferative, mesangial, whether they are exogenous infiltrative, neutrophil within the glomeruli, but much more so monocytes and lymphocytes within the crescent, with time lead to scarring and fibrosis and glomerular sclerosis. So the areas of mesangial cell proliferation will rapidly become areas of mesangial cell fibrosis and sclerosis, as you can see here. And with time, you'll get more and more segmental, meaning part of the glomerulus, and ultimately global sclerosis, as on this slide, and as on these end-stage kidney, where the whole glomerulus has been replaced by a fibrous ball. Once you finish looking at the glomeruli, you move on, and you have to look at the biopsy in a very systematic fashion. You look at the tubule, you look at the tubule structure, you look at their juxtaposition, you look at their cells, cellularity, you look at their basement membrane, you look at their infiltration by inflammatory cells, you look at their lumen to see if it's obstructed by material, debris, cars, cells, and you look around them for the interstitial. So again, as with glomeruli, have in your mind and in your head the normal tubule structure. Back-to-back juxtaposition of tubules, normal cellularity, the whole tubule is lined by epithelial cell. You can see the nuclei, you can see the heightened epithelium, and you can see a small lumen between, allowing for filtration between the cells. Tubule profile are juxtaposed with no space between them for inflammation, for edema, or fibrosis. The lumen is clear, allowing for urine flow, there's no debris, and there's no casts. Contrast this with this image of severe tubular atrophy, and you can see here a tubule which is more or less denuded of nuclei, bar these two cells remaining. Heightened epithelium has disappeared and become atrophic. All you can see is cellular ghosts and the tubule basement membrane. And you can see the broken tubule and the debris within the lumen of these damaged tubules. Between the tubules, you also see that there is huge amount of space. They're no longer back-to-back, and this is either inflammatory cells, as we can see here, or more likely hyalinosis and fibrosis contributing to progressive renal failure. When you look at the tubule cell, you can also identify mitotic figures, and this is a particular tubule that was subjected to acute tubular necrosis with tubular atrophy, with loss of tubule profile along the tubular basement membrane, and then you have regeneration through mitotic figures and proliferation of adjacent cell, and this is a healthy picture of recovering acute tubular necrosis. Another example here is the infiltrating in a transplanted kidney by an inflammatory lymphocyte of the tubular profile, as in tubulitis or inflammation of the tubule, and you can see here as well some interstitial lymphocyte trying to get into the tubule wall and infiltrating as in tubulitis, and more evidence of inflammatory cell within the lumen and within the wall of inflamed tubules. You can also look at the tubules and find sometimes abnormal looking cells, large nuclei, and these are often characteristic of viral infection of the tubule, such as CMV infection in a transplanted kidney, or polyomavirus infection as in BK virus nephropathy, again in a transplanted kidney. So not only you look at the number of cells surrounding a tubule profile, but you also look at the characteristic of the cells, at the nuclei, whether they're mitotic or not, but you also look at their characteristic, whether they're hypertrophied or mitotic or infiltrated, as sign of regeneration or infection. Once you finish looking at the tubule profile itself, you look inside the tubule, and you may find cellular debris in a trophic tubule, the tubule cell falling into the lumen and obstructing it. You may find red cells, such as in severe macroscopic hematuria, where red cell aggregates or red cell casts obstruct the tubule lumen, or as in this case, you may find white cell cast associated with acute pyelonephritis, and again the white cell cast is blocking the tubule and stopping filtration by intratubular obstruction. You may also find crystals, such as in hyperuricemia or hyperoxaluria, for instance. You may find in multiple myeloma these fragmented casts. You can see the fragmentation there, surrounded by giant cells trying to clear these casts and open up the tubule for filtration. And these are light chains, Ben-Jones protein aggregating within the tubule and obstructing the tubule, as in cast nephropathy. So we've looked at the tubule wall, we looked at the tubule cells, and now we also looked at the tubule lumen. And obviously obstruction of the tubule downstream from the glomeruli will also lead to severe impaired kidney function. So we start with normal tubule profiles with cellularity, back-to-back cells, and so on. And we end up with atrophic tubule, hyaline material, protein, cast, debris, and others, interstitial inflammation, and ultimately interstitial fibrosis. Now we look at the vessels, and we can have large artery and atherosclerosis with intrarenal arteries, and very often ischemic nephropathy, where the arteries are atherosclerotic, are associated with ischemic glomeruli, and typically ischemic glomerulus will be shrunken, shriveled, with retraction and a big Bowman space surrounding it. So thickened vascular wall, thickened capillary wall, and small shrunken tubules. Another example of an atherosclerotic interlobular artery there in an ischemic kidney. You can have vasculitic arteries within the kidney, as in systemic vasculitis, lupus nephritis, or polyarteritis nodosa, and again destruction of the vascular wall with perivascular inflammatory cells. You can have in an older patient with ischemic atherosclerotic renal artery disease, cholesterol embolization within renal arteries, and these are the ghosts of the cholesterol crystals causing the occlusion of the artery. Arterioles can be hyalinose, and periodic acid shift will show in red areas of necrosis within vascular of smaller vessels, such as in this case of diabetic nephropathy, and you would get the same picture with hypertension. And this tells you that this patient with diabetic nephropathy is hypertensive because he has arteriolar hyalinosis. You move on to smaller capillary, peritubular capillaries. You look at their lumen, you look at them by electron microscopy in order to see infiltrating inflammatory cells, as in antibody-mediated rejection, and you stain them, for instance, here with C4D, a complement breakdown product, for evidence of complement activation along the peritubular capillary as a sign of inflammation, as a sign of immune response, and as a sign of antibody-mediated rejection of a transplanted kidney. So to conclude the first part of my talk, we go systematically through all aspects of the renal biopsy, starting with the glomeruli, the cellularity, the sclerosis, the patency of the intra-tuft capillaries, the patency of the urinary Bowman's filtering space. We move on to the tubule, we look at the cell wall, we look at the cellularity, we look for apoptosis, we look for mitosis, we look for abnormal nuclei, a sign of viral infection, and then we move on to look at the lumen, we look at debris, we look at hematuria, we look at red cell, we look at cast, and we look at cast nephropathy, as in multiple myeloma and monoclonal gammopathies. We look at the interstitium for inflammation, we look at the interstitium for eosinophils, for instance, in an allergic interstitial nephritis, and we look at the interstitium with Masson trichrome for expanded, hyalinized, and fibrotic interstitium, as in tubulointerstitial fibrosis of progressive CKD. We look at the vessels. We look at large vessel arteries, we look at smaller vessel arterioles, and then we look at very small vessels, capillaries, for sign of inflammation, for sign of atherosclerosis, and for signs of vasculitis. And we rely, as we said, on light microscopy, electron microscopy, and immunofluorescence to get the most comprehensive of picture that will give us a clear-cut, definite histological diagnosis. Now let's move on to the second part of my talk, where I'd like to focus on clinical pathological correlation. So the basement membrane, the glomerular capillary wall, and the endothelial cell. We'll look at abnormalities of mesangium and its impact on hematuria. We'll look at abnormalities of podocyte and basement membrane and its impact on proteinuria. We'll look at the loss of the glomerular capillary space, and we'll look at the loss of the urinary space, affecting filtration and kidney function. Remember that the protein filtration depends on the healthy podocytes and the presence of the slit diaphragms. Now we look at hematuria and proteinuria. And we'll bear in mind that hematuria is a feature of mesangial abnormalities and proteinuria is a feature of podocyte and basement membrane abnormalities. So let's start with the first case. This patient has hematuria 2+, no proteinuria on dipstick, and normal renal function. So hematuria 2+ or 1+, proteinuria negative, renal function normal. Is it glomerular? The answer is yes, if we exclude urological causes. Glomerular. We said hematuria is mesangial. We said normal renal function implies absence of glomerular basement disruption, occlusion of glomerular capillaries or occlusion of the filtration space. And this is typical of mesangial-proliferative glomerulonephritis. So whenever you have isolated microscopic hematuria with normal renal function, always think, once you rule out urological causes, you're looking at glomerular causes, that there is an element of mesangial proliferation. Might be mesangial IgA, but it might be mesangial proliferation within the context of other nephropathies, such as hematuria, within the context of diabetic nephropathy, within the context of membranous nephropathy, or within the context of membranoproliferative glomerulonephritis. Then we move on to, so always mesangial disruption equal hematuria. Always remember that, mesangial disruption equal hematuria. Now we move on to another scenario. A patient with hematuria, proteinuria is negative, and renal function is normal. Actually, that's the scenario we've just been through. So in that case, hematuria is glomerular. Absence of proteinuria tells us the podocyte is healthy, therefore it's mesangial. And the fact that we have endoglomerular proliferation due to mesangial proliferation as in hematuria. Now we move on to another scenario, that of negative hematuria Now we move on to another scenario. This time hematuria is negative, but proteinuria is positive. And again, renal function is normal. So proteinuria equates with glomerular damage, especially severe proteinuria. Apologies for the disruption. So now we go back to another scenario. As we said, heavy proteinuria suggesting glomerular pathology. But in the absence of hematuria, it's not mesangial. It's likely to be either the podocyte or the basement membrane abnormality. And the fact that the renal function is normal tells us that there is no obstruction of intraglomerular capillaries or obstruction of the Bowman space. So we said mesangial disruption is hematuria. Now we have, in this instance, proteinuria equates to disruption of the podocytes or the slit diaphragm, as in, for instance, abnormality of the podocytes acquired or genetic, or damage and thickening of the basement membrane. So the podocytes are damaged, therefore the food processes are effaced, or the basement membrane is thickened, as in membranous nephropathy, where we have immune deposits either along the subepithelial space, as in membranous, epimembranous deposits, and it is the abnormality of the podocyte, the basement membrane, and the interface. And you can see the immune deposit sitting on the slit diaphragm and interfering with podocyte function and causing the thickness of the basement membrane. That abnormality of that complex podocyte basement membrane will lead to proteinuria. If we have a combination of both, then we'll have hematuria as well as proteinuria, as we've seen before. So now the mesangial cell proliferate will cause hematuria, and the thickness of the basement membrane and the associated abnormalities of the podocyte will cause proteinuria. So you can see mesangial proliferation in a number of instances. GBM disruption is proteinuria. Therefore, podocyte abnormality, basement membrane abnormality, and GBM disruption. You can have both hematuria and proteinuria if you have an element of mesangial proliferation in a condition associated with GBM thickness or podocyte abnormality. And this could be, for instance, minimal change with slightly mesangial proliferative changes, as in IgM disease. It can be IgA proliferative mesangial changes with an element of damage to the basement membrane or the occasional crescent. You can have membranous nephropathy with small foci of segmental mesangial proliferation. You can have mesangial capillary glomerulonephritis, where you have mesangial proliferation and capillary thickening. And you can also have hematuria and diabetic nephropathy, whereby you have thickened basement membrane associated with small areas of mesangial proliferation. So whenever you have 1 or 2 plus blood in the urine, even in diabetic nephropathy, tell you that's a sign of mesangial proliferation. Whenever you have proteinuria, tell yourself that's a sign of basement membrane disruption and podocyte abnormality. Now, what if the two are combined with a slow progressive decrease in kidney function? Well, it could be that either the mesangial proliferation or the podocyte abnormality and the basement membrane has led to progressive areas of sclerosis, segmental glomerular sclerosis, more glomerular sclerosis, and as we've seen before, global and more severe glomerular sclerosis associated with progressive renal failure. Now, what about hematuria or proteinuria with severe renal function impairment? Mesangial proliferation in itself will not cause severe renal function impairment. Disruption of the podocyte or congenital abnormalities or acquired injury through immune complexes or otherwise will not cause severe renal function impairment unless there is occlusion either of the intraglomerular capillaries, as in a proliferative where there's hardly any glomeruli left, endoglomerular proliferation, or extracapillary proliferation where there's no room to filter, therefore the renal function will be severely impaired. And these are usually associated with severe disruption of the basement membrane, causing proteinuria, causing hematuria, but also hardly any space for the urine to filter. So proliferating, obstructing nephropathy. Another example there, this glomerular tuft has hardly any capillaries to filter, and even the remaining capillaries that may be patent to filter will have no room to filter into as the Bowman space is occluded. And you can see very often associated with severely damaged glomerulonephritis, breaks in the basement membrane where the cells filter into the urinary space, so you get hematuria, you get obviously heavy proteinuria, but also these cells will form the nucleus of the proliferating crescent within the Bowman space and the urinary space. And again, you can see by electron microscopy holes in the damaged glomerular basement membranes through which heavy hematuria takes place, heavy proteinuria can take place, but also cells infiltrate to cause an occlusive crescent. Now let's move away from the glomeruli into a completely different scenario whereby there's no hematuria, therefore no mesangial proliferation, mild proteinuria, less than 1 gram per 24 hours, suggestive of interstitial damage, tubulointerstitial damage, Because don't forget, the protein is filtered by the glomeruli and reabsorbed by the tubules. Tubule damage will give microalbuminuria and can also give low-level proteinuria and normal renal function. And that's very often symptomatic of mild tubular damage. You see a few missing nuclei there. But the lumen is patent, so renal function is normal. Mild interstitial nephritis, few inflammatory cells causing tubular disruption and decreased reabsorption of filtered protein, hence low-level proteinuria. So it's interstitial. Now renal functions start to decrease. So we've got the interstitial element, mild proteinuria, either tubular damage, decreased reabsorption of albumin, mild proteinuria. But now renal function is decreasing. Renal function is decreasing either due to severe interstitial nephritis, now damaging and destroying the tubules, causing acute tubular interstitial damage, or severe tubular atrophy, as in acute tubular necrosis with debris obstructing the flow of urine and impeding and affecting renal function and causing acute kidney injury, or obstruction again of the downstream from the glomeruli flow within the tubules due to not debris this time, but instead white cell cast, red cell cast, macroaggregates of red cell as in severe hematuria, or myeloma cast and Benz-Jones protein cast. So as we said before, renal function can be affected not by glomerular sclerosis but by interstitial fibrosis and back pressure on the glomeruli, also causing glomerular sclerosis. Or we start with glomerular sclerosis, tubular interstitial ischemia, and progressive atrophy of the tubules and their replacement by interstitial fibrosis and inflammatory cells. Now take this scenario of hematuria, heavy proteinuria, and declining renal function, absence hematuria, heavy proteinuria, and progressive renal function. The heavy proteinuria likely to tell us that there is podocyte damage. We know that we started in the previous case progressing to that case to heavy proteinuria, and we know that the renal function is impaired. We had a biopsy showing interstitial nephritis. Proteinuria was 1+, now proteinuria is 3+. Why? Because we have secondary glomerular sclerosis, damage to the tubules, puts back pressure on the glomeruli, which in turn become obstructed and progressively sclerotic. So secondary focal glomerular sclerosis in a patient with initial mild proteinuric interstitial nephritis translates into heavier proteinuria, even sometimes nephrotic range proteinuria, as in a patient with chronic pyelonephritis due to secondary glomerular sclerosis, secondary damage of the podocyte, and secondary damage of the podocyte-basement membrane complex, leading to, again, end-stage kidney. Finally, don't overlook the presence or absence of hypertension. So the patient, for instance, with proteinuria, impaired renal function, hypertension, tell us, regardless of the etiology of the proteinuria, it could be glomerular, it could be podocytic, it could be basement membrane, impaired renal function, could be occlusion of the glomerular capillary area, or occlusion and obstruction of the tubule, or their progressive fibrosis. Association with hypertension tell us, look at the intrarenal vasculature. Look at arteriolar hyalinosis. So this patient is diabetic, thickened basement membrane, he'll have proteinuria. Areas of mesangial proliferation, he'll have 1+ blood in the urine. Heavy proteinuria due to thickened basement membrane. There's still some residual renal function due to the free Bowman space and patent capillary and fairly healthy tubule, but this patient is also hypertensive as shown by the associated arteriolar hyalinosis. Patient could be older with atherosclerotic renal artery disease. He'll have atherosclerotic changes. So to conclude my talk, I've shown you the histological changes in the first part. I've tried to convince you and show you that you can, through urine analysis and renal function evaluation, predict to some extent the pathological correlate, mesangial proliferation as shown by hematuria, damage to the podocyte basement membrane complex as shown by proteinuria. Changes in the renal function as shown by damage to the glomeruli, either in the form of occlusion of the tuft capillaries or exclusion of the extracapillary Bowman space, occlusion or obstruction, or progressive sclerosis and fibrosis of the glomerular tuft, or changes in the tubules in terms of tubular atrophy or tubular obstruction by debris, red cells, or casts. I will not go through the quiz that I was planning to go through with you, but I'll put this quiz on the online academy for you to have a look. And the quiz will tell us, for instance, patient with heavy proteinuria, no hematuria, impaired renal function, and no hypertension. So this patient is likely to have podocyte basement membrane abnormalities without mesangial proliferation, sufficiently enough to cause sclerosis or occlusion due to thickened basement membrane of the endo-tuft capillaries. Take another example, no proteinuria, mild hematuria, hypertension, so perhaps mesangial proliferative glomerulonephritis and arteriolar sclerosis, and so on and so forth. And we can play with these into permutation and come up with a quiz, and I'll put this on the online academy for you to look at. Finally, I'll encourage you all to join the Global Kidney Academy online academy, and I've put the website. We can extend this discussion and also cover other discussions that have taken place during your 2 days of the Preston International Renal Biopsy course. So you can ask some of your speakers, you can get reply, and Eamon will lead on this site, which is already available on the forum of the Global Kidney Academy. I take this opportunity of thanking you and also drawing your attention to the prize that the Global Kidney Academy and the Preston course has decided to give to one of you, which is free access to one of our nephrology online courses, mainly the forthcoming transplant online course due to start on October the 1st, 2014, and Eamon and the faculty of the Preston course will choose one of you as the winner of the 2014 prize of the course and will offer him or her free access to the course. Others are welcome to join the course, and the course fee is accessible and reduced to $250 for members of the Preston course, and Eamon can tell you how to apply for the Global Kidney Academy or nephrology online courses, whether it's our CKD course or whether it's the forthcoming October 2014 transplant online course. Thank you very much for your attention, and apologies once more for the odd disruption in my presentation, but also for not being with you, and enjoy the rest of the course.